Hi, Olivia.
Hi, Uli, how are you?
Thanks. I came 10 minutes before just to test and make sure that everything is okay.
Okay, great. We do have a lot of people that are here already.
Mm-hmm.
Welcome, everyone. If you hear us, we're going to do some testing, so please don't mind what we will say now.
Mm-hmm.
Okay, sorry. So hi, we have Jessica by the beach, I think.
Hi, Uli.
Wow.
Hi, Olivia.
Wow. So jealous.
Wishing I could be at the beach.
This is a fake. It's a
picture. It's Diani Beach in Kenya.
Oh, you really got us. I was like, no, I cannot do this. I'm not looking at this. I'm a bit too jealous.
Yeah, it looks
amazing. Where are you, Jessica, in the US?
I just got back from vacation actually last night.
Oh, okay. So where were you in vacation?
I was in Martha's Vineyard near Cape Cod. It's beautiful there. We had such a nice time.
Ah, so glad to know.
And how are you doing, Uli? Everything's fine?
Yeah, everything's fine. I'm in Geneva, obviously.
Yeah.
We might little by little now go back to the office, but we've been working from home since March.
That's amazing.
Yeah, it's a long time, huh?
And all your family in Brazil is okay?
Yeah, I mean, it's such a complicated situation now in Brazil. My family is fine. I mean, you know, like people are not working, kids not going to school, but other than that, it's fine. Good. Everyone is well protected. Yeah. And your family in the US?
Everyone's good so far. Although we hear this news from Dr. Fauci is very disconcerting that it could be 100,000 cases a day. It's just shocking.
Jessica, we have the worst presidents.
I swear we do.
My God, like we have the worst.
The worst.
Yeah. Okay, so Alexis joining soon, I guess.
Yes. Yeah.
Okay. Okay, so we will go on mute. I think everything is working very well. So we do have the slides. If you want, we can show them for you.
Yeah.
Yes. Okay. So we put them in
order. My screen.
Yes. Jessica, you want us to share it to show them for you, or you want to share your screen?
I'll share my screen.
Okay. Perfect. So we will start with.
I was thinking maybe I will try to share mine.
We can share it with you.
Hi everyone, how are you?
Hi Alexandrina, welcome. We're doing a little sound check now before we start. How are you?
Oh, you're on mute.
You're
on mute.
Okay.
I'm sorry, could you hear me?
No, you were on mute.
Now we can hear me.
Okay. Well, it's good to see you all. I was saying that I see that my Pokemon posters are in the screen, so I'm going to try to find another angle so no one can see my Pokemon posters.
Oh no, we like Pokemon posters. Feel free to use it.
You may not add to the topic of the webinar though, so give me a second.
So we do have participants already. A lot of participants are online already, so they are hearing us. So if you hear us, we are just doing a sound check now, and we will start 2 minutes after 2, so in a few minutes.
No
I think everything is good. We can go on mute and then come back in 5 minutes.
Okay.
Perfect. So see you in 5 minutes, everyone. to me. Okay. Welcome everyone. Welcome to the Malaria Matchbox webinar. We will start in about 3 minutes. We have a lot of people who are joining us now, so we will just give them 2 more minutes for them to join. So thank you very much to everyone who are online already. We are seeing a lot of leaders from National Malaria Control Programs, from CCM, from civil society organizations, also partners at RBM, MMV, and others. So thank you very much for joining. And we have several people who are joining us now. So we will start in just 3 minutes. Thank you very much. Well, okay. So good afternoon, everyone, or good morning if you are by the beach or in another continent. So my name is Olivia Ngu. I am the executive director of an NGO called Impact Santé Afrique, and we also host the secretariat of the Civil Society for Malaria Elimination Network, which is a global network of civil society engaged for malaria elimination. So we are very, very, very happy today because we have a wonderful panel of experts from the Global Fund and also from the International Public Health of advisors who are here with us to talk about and to present to you all the Malaria Matchbox, which is a new tool that is very effective and that can actually help to assess the equity and also improve effectiveness of malaria programs. So we do have today with us almost the founder of that tool. So we will hear all about it, and we will also have the opportunity to hear some recommendations from the Global Fund and from Jessica Rockwood on the malaria grant concept note to really improve the area of human rights, gender in malaria. So we know that this is an area that needs to be strengthened and to be reinforced in concept note, but also at the level of implementation. So we hope that this training will help and will provide some tools and some knowledge on how to really include and ensure that community rights, gender issues are well included in malaria programs, to make sure that we can reach more communities and make sure that we can reduce inequalities in terms of access to malaria services. So thank you very much for joining us from several countries and several regions. We are excited to have you all. And we're going to start now because we are going to have a full hour of great discussion and presentation. So what we will do in terms of the agenda, we'll have a presentation first from the Global Fund, and after we'll have a presentation from Jessica Hopwood. And then after that, we will open the floor for question and answer. So please, during the webinar, feel free to write your question in the chat on the Q&A window. Yes, on the Q&A window, you can write your questions as we go, and we will answer them at the end. And we also have a lot of people following us on Facebook Live now. So if you're on Facebook, please write your questions on the Facebook on the Facebook page, and then we will make sure to read them during the question and answer session. So thank you very much, and I will hand the floor to Uli. So Uli, if you want to introduce yourself, and we will go on to the next slide.
Sure. Thank you so much, Olivia. Thank you for this invite. I'm very happy to be here, and even happier to see the number of participants that we have in this session. I'm really glad that people are more and more interested in the malaria matchbox, more interested in really understanding how we address gender and human rights issues into malaria programming. So. First, so if you can go to my slides, or I should maybe, okay, that's great. But first I would like to say that for me, it's also a pleasure to be particularly in this panel. So you asked me to talk about the history of the matchbox. And I'm glad to share the space with Jessica Rockwoods. She was actually the person that back in 2016, when we were working together, actually I was not part of the initiative yet, but our Community Rights and Gender Strategic Initiative, which is an initiative looking at community engagement in global fund processes, started to work with Jessica. And given that at that time we had several concerns already from the technical review panel of the Global Fund when looking at the applications, there were several concerns related to lack of integration of human rights and gender issues into malaria programming, and we wanted to address that. We wanted we are the department in the Global Fund that is looking at these issues, and we really wanted to address that. We worked with Jessica to develop a tool that initially would be looking more specifically at global fund investments. So it would be something that we would be offering to our country team so they could look at it, they could analyze who were the populations that were left behind, what were the barriers that they were facing in accessing the core malaria services, and then what could be done. So it's really like that had a very limited scope at the beginning, really try to improve the quality and coverage of our malaria grants. And then we started with this tool, being supposed to be really an internal tool, and we once we started with the pilots. We did the first pilot in India and the second pilot in Niger, for which Olivia, you and your team did a great work in piloting the tool in Niger. And after that, more and more people and partners and organizations really started to be interested in the Matchbox. And today, what we have is a tool. We finalized the tool with the RBM partnership to end malaria. We had the review from several other partners organizations. We received inputs from several specialists, that some of them, and I can see some of them are in this session. So thank you very much for everyone that contributed to this too. And now we can offer something that is not really limited to our grant global fund investments, but it can be used by any malaria national program. It can be used as a resource, not only as an assessment tool, but also a resource tool where you can have information, right? You can read and have a better understanding on how you actually look at specific populations that might be not really entirely benefiting of malaria services, and how you can address that. So it's really a resource too that I invite everyone to take a look. It's currently in this link that you can see in the slide presentation, and anyone can have access to this. So next slide. The malaria matchbox as a resource tool, it really wants to bring us to the understanding of who are the most affected populations in when we talk about malaria. And the key point is it's really assessing the risk for malaria infection in disease progression by simultaneously consider the epidemiological factors, entomological factors, and social factors. And when you take those factors, you can have not only what the WHO, the definition that we have from the WHO for high risk populations is only focused on those populations, those group of people that will have more vulnerability, that will have less immunity because of the biological conditions. So you have pregnant women and infants, where most of malaria programs will be targeting children under 5, migrants and mobile populations that are moving from low incidence areas to high incidence areas, and other populations that will have lower immunity than when compared to the rest of the population. So those is like exclusively looking at biological factors. But you also have populations that are also affected by social factors. So what we did in the matchbox, we are looking at populations that are the high risk of infection because they are exposed to the vector, and that might be because of sociocultural behavior factors. You have risk population of developing the severe disease, and that is again related to the definition of WHO for high risk populations. And you have high risk populations, high risk of mortality or morbidity, due to both biological factors and lack of access to adequate healthcare. And this is what we call the underserved populations. So the matchbox brings us this understanding, brings us this concept of in underserved populations, and suggests the malaria programs move beyond from the traditional programming that is largely focusing on core interventions and interventions targeting high-risk populations, consider only the biological factors, and move to a more comprehensive human rights and gender-based approach that will really take into consideration that malaria is a disease of poverty, and you have several aspects of social exclusion and discrimination based on gender, language, age, legal status, and other barriers that will make people be really more prone to suffer consequences of malaria. Next slide, please. So again, this table is on page 11 of the matchbox for those who have the document open. Again, like listing the biological factors, and the socioeconomic and cultural factors such as poverty, social exclusion, gender inequalities, financial barriers, cultural norms, and complex emergencies. And then you have some examples of the populations that are most impacted. And as you see in the underserved populations, you have populations that are impacted by conflicts, including refugees and internally displaced people, populations living in remote areas that are facing geographical barriers to access basic services, women and children living in poor settings, undocumented workers that are not able to access primary health care because their status, indigenous populations that are also not reached by the traditional health services, ethnic minorities, and so on. So each country really has to look at their barriers to be able to identify what are the underserved populations. So this list is not exhaustive list. It's just some examples. And the important thing is also to understand that often populations having low immunity to the parasite, or as we discussed, the populations that are considered high risk populations by the WHO definition, they tend to be often underserved by services. And therefore they will have a double burden that they will have cumulative vulnerabilities. So for instance, pregnant women that will be at a greater risk of developing the disease because of developing severe disease because of their lack of immunity, because the low immunity, will also face barriers to access services that are linked to poverty, lack of access, lack of transport, lack of financial means. And an example is that in 2017, the WHO estimated that only 54% of women received at least one intermittent preventive therapy in pregnancy, knowing that this is not even enough. So the number of women that receive more the complete set of doses is even less than that. And migrant refugees and internally displaced people as well, they have they might have increased exposed to malaria. They might be also if they are coming from a region that is not with low incidence, they might also be more biologically vulnerable to developing severe disease, and they will often be the ones that will face the biggest barriers in accessing services because of the language barriers, legal status, discrimination, or lack information. Next slide, please. So this is just an overview of the malaria matchbox, and you can take a look at the assessment part. So basically, there are several sections in the matchbox, or better saying, different sets of questions. But this is an illustration on how it's organized. So you have questions, and then you have some considerations that includes a lot of examples from countries, from several countries, that will help you really to understand the rationale behind the question and what researchers will actually have to look at when they are asking those questions. Next slide, please. So this is when we did the piloting, we developed this structure for the tool, for implementing the tool. So you see from one side, you have the pre-assessment. So some prerequisites that we really need to be met before the actual assessment. And then in the right-hand side, you see the actual assessment. So it is important to say, it's important really to consider that for the pre-assessment, you really need to understand the country context and the response, and find the gaps. So as I say, this is a resource, this is an assessment tool based on more qualitative analysis. And the way that we have been working with the pilots is really to try to understand what is how the country responds to malaria, what are the main issues, and especially where are the gaps in terms of information, because it's where the gaps are that we will try to collect information through the matchbox. It's really important to secure multi-stakeholder commitment. As we've been discussing, malaria it is a disease of poverty. There are several other issues that are related to how we respond to malaria that is not only related to core programs, but it's also related to how people actually access services, primary health services in general. So it's not only important to have the commitment of the malaria program, but also other stakeholders that will influence on how the overall planning that responds to the issues that we find will be agreed. Then it's really important to have a good assessment team with people with knowledge on malaria programming, but also knowledge on human rights and gender issues. It's really, really important to have involvement of civil society, because those are the ones that really have a closer link to the beneficiaries, and we will be able to respond to a lot of questions that the tool is doing. It's not really so this is an operational research, and the scope of the research will also determine the budget. So you can, for instance, do the assessment in one state, one particular space in your country, or you can do a national assessment. So that will really influence planning and budgeting. Then developing the research proposal and ensuring that ethical considerations are observed. So often in countries such as Niger, for instance, we were requested to present a very detailed research proposal and submit it to the ethical committee. So in the right-hand side, we have the assessment, and this is more or less how the set of questions are organized. And so module 1, 2, and 3, they are organized in set of questions that will lead you to identify who and where the populations most impacted by malaria are, the risk factors, the barriers to access services and service deliverers, and the bottlenecks that are affecting health equity in the context of malaria. And then also identify intra-household inequity and gender issues. Module 4 and 3, they're actually the phases where we look at the results, and together with stakeholders, we do an action planning to respond to those the issues that were found. Next slide, please. So this, I will. So my colleague Alexandrina will speak more to the potential barriers. But I think one important thing of this slide is that the matchbox does not ask you to, will not suggest you to really create programs, create standalone programs to address human rights or gender issues, but will rather make you look at how core malaria programs are designed and are implemented, and we'll try really to suggest that those programs are improved, that you have a better you really mainstream gender and human rights approaches to ensure that populations are not left behind. So as we had in some, like most of the countries where we've been doing this, the malaria matchbox led us to look at IEC strategies and make it more comprehensive to make sure that all populations can access it. We had also looking at how pregnant women and children can better access antenatal care or other services.
So it's really important to take into account that what the matchbox is proposed is really a way of a more comprehensive way and more responsive way of designing malaria core programs. Next slide, please. Yes, so some of the main outcomes, as I say, we did a pilot in India, we did in Niger, and we did in Guinea-Bissau. So as I said, in India, it helped us to really look at the IEC strategy for the populations living and adapt it instead of a overall strategy. There was an adaptation of those strategies for populations that were living remotely, migrant workers, urban land dwellers, and tea garden workers. So those are the populations that were identified by the exercise as being less served by the services, and that also include awareness about the role of community health workers, who are often not known by this population. In Niger was really interesting, and I'm sure that Olivia can talk more about that, but it was really interesting to see women not being able to access healthcare services and to take their kids to the hospital when they had a fever because they were not allowed by their husbands. So there was a whole discussion on how we actually make sure that there's linkage to care for this rural woman living in remote areas. And finally in Guinea-Bissau as well, we had very interesting findings that really brought us evidence on the need for better targeting of fishermen in migrant communities from Guinea-Conakry and the Taliban kids that were in malaria programs, and also action planning for improving linkage to care for communities living in island. So that's very one important thing is that those exercises and the whole dissemination of the malaria matchbox also led to several countries to include the matchbox, or even the TRP, the technical review panel of the Global Fund, also suggesting the inclusion of the matchbox in the funding requests. So as my colleague Alexandrina will say, out of 11 malaria requests that we TRP reviews on malaria requests that were already released, 6 are mentioning the matchbox. So I will stop here, and I will hand over to my colleague Alexandrina, and after I'm also happy to take questions. Thank you, everyone.
Thank you so much, Uli, and thank you for making that segue into the lessons learned from the first window of our technical review panel. So without further ado, if we can go to the first slide of my presentation, the malaria information node starts from providing guidance on how to complete the funding request. And among the essential and key points that it asks the funding request to include, in the summary of country context, in the frame of malaria epi data, it also asks to include as relevant data and details on the vulnerable populations and on the barriers, including human rights and gender-related barriers that they may experience. Why is this important? This is important because it allows you to contextualize, to understand how to better target the malaria interventions. The technical brief on malaria, human rights, and gender specifies specific programmatic interventions aimed at addressing such barriers. Those are around assessing and understanding better what are the inequities, human rights, and gender-related barriers, including using a tool as a matchbox. Those are around supporting health and community systems in order to adapt to gender-specific service delivering needs. This is around meaningful participation of affected communities and affected populations in order to ensure the quality of the interventions, and in order to ensure the uptake of such interventions by the affected populations. The technical brief also speaks about the need to strengthen community systems that allow for the participation of communities, of affected communities in the malaria programs, and various roles that the affected communities can undertake in that particular framework. The technical brief also speaks about the need to ensure that the laws, regulations, and policies provide for an enabling environment for the malaria prevention and control. But perhaps even more important is that the technical brief recognizes that specific programmatic approaches to address gender and human rights related barriers cannot happen in isolation. They need to be part and parcel of the malaria module interventions. As such, whenever we're planning for ITN use or for IRS or for IPTP, we need to look into what are the people that are underserved and left behind, and what are the barriers, the gender and human rights related barriers that are conspiring to leave people behind. And same is true as we approach case management. So if we'll go to the next slide, I'll introduce basically what the first window of a TRP review had to contend with. So there have been 45 funding requests that were examined by the TRP. All of them have also included prioritized above allocation requests, so TRP has been busy. The second window of review has just started, so the TRP continues to keep busy. In the first window, 51 or 78% of the 65 components were allocated greater funding than in the previous cycle. With great opportunities also comes great responsibilities. So we need to ensure that these increases in the allocation actually mean that we are implementing effective interventions, efficient interventions, but also that we address the inequities and we ensure value for money in those investments. Quite a few of the funding requests that we examined, 14 of them actually included catalytic matching fund requests. So that again represents an opportunity to catalyze and include specific focus and action. Out of those that were recommended by TRP to proceed for grant making, it actually represented 4.2 billion in allocation funds, or 33%, 1/3 of the overall country allocations for the 2020-22 period. The TRP has produced a report with lessons learned, with some important lessons learned that looks into what can we do better as we move forward to ensure that the other 67% of the funding requests that are yet to be reviewed learn from the lessons of the first wave. And the TRP has encouraged applicants to use robust data, to use that data to guide choice of interventions, including through stratification of such data. It has also encouraged applicants to consider also what are the barriers to the uptake of services. So to consider not just availability of services, but also what makes such services and commodities accessible and acceptable and enhances the quality of behavior change communication. It has also encouraged applicants to fine-tune the analysis of risks and barriers and to better track progress in removing such barriers. And actually this slide and the next tries to break down exactly that. Where could we improve the investments for addressing barriers to services in order to reach the underserved and unserved populations? So first and foremost, when we are aiming to scale up the programming for high risk and hard to reach populations, we should look at the epidemiological and programmatic data. What does it tell us? What are the gaps? How do we prioritize better the interventions? And how do we better target from a geographic and ecological perspective? For example, we have a rural-urban divide in terms of malaria prevalence, but also in terms of services, access to services. How do we better gear our response to address such geographical disparities? But TRP has also assessed and acknowledged that there has been a particular gap for mobile populations, including internally displaced persons and refugees. It has also flagged the value of cross-border collaboration aimed at ensuring access to services for mobile and migrant populations. But TRP has also encouraged applicants to include funds for qualitative assessments. And as Uli has said, in 6 specific cases, there was specific reference made to the malaria matchbox as a recommendation from TRP. In some other cases, actually that takes us to 11 countries, the malaria matchbox has been mentioned as a potential strength for the funding request, as in the case of Nigeria, or in the case of Guinea-Bissau, follow up to the malaria matchbox findings have been among the TRP recommendations. Why is such qualitative data important? Because it allows us to better understand the barriers to services. It better allows us to understand which inequities exist and how can we best address such inequities. The TRP has also advised including funds for technical assistance in order to translate this evidence, the quantitative as well as the qualitative analysis, into solid programming that is based on contextually grounded evidence on what the inequities are and how we best address such inequities. The TRP has also requested for investment in integrated training and other capacity building activities. We know that evidence tells us that one-off trainings does not really help move a needle. So it is important to plan in a comprehensive manner. And it's also important that we use all the opportunities to integrate equity considerations in such trainings, rather than go for standalone human rights equity trainings, integrate such components in all the capacity building activities. If we'll go to the next slide, please. It takes a while for it to load. So another set of recommendations were around how do we optimize the investments in the health and community systems in order for such systems to maximize the impact on malaria control and elimination. So the TRP has recommended prioritizing generating high quality data, but also ensuring that such data is integrated into national systems rather than vertical systems and silos. The complementarity of qualitative data when quantitative data does not suffice has again been a recommendation from TRP. But TRP has also flagged about the role and potential that community-based organizations can play, including to help collect data from key populations, from vulnerable populations. Community-based monitoring is a useful tool, providing feedback loops between the service providers and the beneficiaries of such services. It's a useful tool to be able to capture whether services are available, but also accessible and acceptable, and the quality of services guarantees uptake of such services. It's also an opportunity to be able to flag stockouts, to be able to flag underserved populations that are being left behind. But TRP has also asked applicants to consider sustainability in promoting long-term integration of the 3 diseases with other basic health services, particularly reproductive, maternal, newborn, child, and adolescent health. And finally, promoting community health strategies, ensuring that the services are best delivered for community actors, including the strategic use of community health workers, of community-based organizations, of community-led organizations and groups, of allies among civil society has also been an important recommendation. And investments in the human resources, they should be considered strategically. There has to be a sustainability plan in mind for the short and longer term, because such investments cannot go on forever, and it is important that they build a foundation for sustainable provision of services. And if we'll go to the next and final slide of my presentation, this captures actually an analysis that has been done on the inclusion of refugees and internally displaced persons in the Global Fund funding requests in the 2017-2019 period. This is work that has been done by UNHCR with a series of partners. What we'll see is that quite a few funding requests do not mention refugees or internally displaced persons, but even those that mention needs of refugees and IDPs sometimes stop short of addressing those needs. So you have 46% of funding requests, malaria funding requests, mentioning refugees, but only 36% including specific activities. Even worse is the situation where internally displaced persons are concerned. Internally displaced persons being away from their homes, being unable sometimes to access their usual health service provision. So it is important that we don't just stop at analyzing barriers using the matchbox, but we use those data strategically. We use that data to inform action planning. And we use that data not in a disconnected manner, but as part and parcel of planning for malaria response that reaches all those that need malaria services and helps us end malaria. Zero malaria starts with me. I'll stop here and answer any questions that you may have.
Thank you. Okay. Thank you very much. Thank you, Alexandrina. This was great. Thank you very much. So we will go to the last presentation by Jessica, and then after that we will do the question and answer. So everyone, please feel free to write your question in the Q&A window or little box that you have under your screen. And please indicate your name and your country. And then at the end of the session, we're going to read all of your questions. So Jessica, do you want to share your screen? We can do it now.
Actually, I'm having an issue with that. Can you go ahead and do it?
Yes, sure. Okay, go to Jessica. Okay, so we will share your screen and we'll start with you now. Thank you, Jess.
So you guys are going to pull it up?
Yes.
Okay.
Okay, so Jessica, if you want to go back, if you want to start by introducing yourself, please, it will be great. Thank you so much.
No, that's great. Hello, everyone. Thank you for joining. My name is Jessica Rockwood. I'm president of International Public Health Advisors. And as Uli mentioned, I was part of a team working on the development of the Matchbox beginning in 2016. And that team included NGOs from around the globe, We had East Africa, we had Kenam, we had Abkhazia from Asia, East Asia, and Rame from West Africa. So it was really, it took a lot of effort to get to the point where we felt that we could go out and begin doing country consultations. Next. Next slide, please. Thank you. Now, Uli mentioned this, but I want to highlight that we had a very, very hard entry point into the malaria community relating to key populations because we were using HIV/AIDS terminology. Once we were able to change our language and really make people understand that that we were not looking only at those communities that had very high burdens of HIV, but that were underserved populations, most vulnerable and high risk. I won't go through this slide. Uli already went through this, but I think the one thing I can say is the one community that is missing in here that we kept bringing up, but has a generally hard time being looked at relating to malaria services are the disabled populations. And so again, this tool is not just, these are not the only populations. These are, you're going to have to look at what populations exist in a country and then look at how to serve them, what community groups are available in the areas in which they're located. Thank you. Next. Next slide, please. Great. So beginning in 2016, we, as I said, we worked very hard with the CRSPC of RBM, which is the country regional partner committee, on really looking at how we could get countries to understand that based on the definition of universal coverage, that as defined as 80% of the population, you're missing 20% of a population. Who are those populations? So I won't go through all the countries, but you can see that we held consultations with 34 countries. And then in addition, we also did face-to-face feedback for a number of countries, and that has continued through this year. What we have seen, and it's very clear to me and in my opinion, that countries require assistance in identifying populations and services needed for all at-risk groups beyond pregnant women and children under 5. Next. Next. So I'm going to take you through some of the lessons learned from the previous TRP windows. And I think we've moved on from there, and I hope to see some differences with the next waves of funding requests. But for window 1, you can see there that funding requests describe key populations in different areas. There was, however, no description on how to provide services to those high-risk groups. And this continues to this day. Next. Then we can also say for HRG on data and data for key and vulnerable populations, again, relevant key populations are not consistently addressed in malaria. Then also, of course, people in closed settings not widely addressed in HIV, TB, and malaria funding requests. Next. Then when we look at window 3, you can see that, again, that they are recognizing that there are key and vulnerable populations, but interventions are not proposed and not budgeted. This continues to happen. And I think we just need to work with countries a little bit more to make sure they understand the budget impact of actually reaching those populations that don't have access to services. And then, of course, again, which has been mentioned before, we're looking also at mobile and IDPs, mobile populations, IDPs, and refugees. Next. So what you'll see here is the TRP observations from that 2017 to 19 cycle. In many countries, the effectiveness of the responses is impeded by the many forms of exclusion from services faced by key populations. And I would say again, that includes disabled populations. Some requests lack targeted interventions to meet the needs of the communities. We know that in many cases, malaria programming is top down and not bottom up. We need to increase the use of robust data in identifying and targeting those populations, and especially important not only for populations like migrants, but also those hard to reach in geographic areas. We need to strengthen integration with other health delivery services and scale and reach particularly vulnerable and isolated population. And then, of course, strengthen cross-border collaboration. I think that the last point we've really done a very good job working on, but I still think that there's some missing links in there. Next. So again, gender analysis is frequently missing, and particularly with respect to TB and malaria. Prisoners and detainees and mobile populations, I can tell you that for prisoners, I have seen very few funding requests actually mention them. Again, they're not budgeted for, and if they are, we need to look at what interventions are giving to them. We should either use IRS or we should use case management. You should not provide bed nets to prisoners. Further analysis of human rights issues seems not to translate into well-resourced, sustained programs. That was mentioned earlier. And then the data remains inadequate on the size and location of those populations. For community strengthening, it is often limited to service delivery, which is not what is needed. We need to engage communities in monitoring the access to and the quality of those services, ensuring that the communities know their health rights, and establishing those community-based mechanisms for people facing discriminations and other barriers to care. Next. Now, the one thing that I have been advising countries to do is to do a mapping exercise of those displaced populations. What you'll see here is from Burundi. I do have this in English. If anyone is interested, I'm happy to share that with Olivia. And what you'll see is displaced populations, where they are, how many are they, what are their obstacles, and what kind of intervention do you need to give them? And you'll see that that goes for infants, it goes on to various different groups. Next. So I think what we wanted to ensure is that the malaria matchbox tool, which has been developed, is taken up by all malaria partners, and that really this will help us reach all of those populations. Thank you so much.
Great, thank you very much. Thank you, Jessica. Thank you, Uli, and thank you, Alexandrina. We see a lot of comments in the chat. Great presentation from Cecilia, from Ghana, and you have also greetings from Uganda, from Tanzania, Nigeria, Cameroon, and many other countries. So thank you very, very much for the great presentation. Now we will move on to the question and answer session. So we have started to receive some session in the chat. So if and in the Q&A box. So if you have a question, please, you can write that down in the Q&A box. If you do want to speak, raise your hand and please make sure your microphone is on, and we will end you the floor. So, so very quickly, I will start with the first question for Uli. So, Uli, so the first question was: is the malaria matchbox tool only is it only used for global fund programs, or can country use it beyond the Global Fund program? So that's the first question for you, Uli, and I'll go also with a second question for you is how probably who are responsible to conduct the malaria matchbox assessment? Is it the civil society or is it the malaria program in the country? So Uli will probably take 3 questions at the time, so we can give you the time to answer those 3. So the first one was about, is it only for Global Fund program? The second question is who is responsible to conduct the matchbox? Is it civil society or is it the malaria program? And the third question is, if this can be done by civil society, is there any technical assistance from the Global Fund to apply in order for them to be able to conduct such exercise? So here are the 3 questions so 2 of them are from Jonathan and 1 of them is from Andre.
Sure.
Thank you, Uli.
Thank you for these questions. So just to clarify, this is a resource that that the Global Fund, more precisely the RBM partnership. So we handed over the tool to RBM partnership, which is who is now also responsible for disseminating the tool. As explained, when we thought about the tool when it was first conceptualized in 2016, we didn't have the intention to get where we got today with this tool that we really published and we are making available for everyone. The idea was primarily to support the country teams in the countries to better understand, better apply gender and human rights lenses in the programs funded by the Global Fund. But then, so as we started to do the piloting and also disseminating information about the tool, and also a natural movement of malaria communities that are increasingly looking more and more to human rights and gender issues impacting on malaria outcomes. That the more and more partners, technical partners, and malaria and civil societies working with malaria started to be really interested in the malaria matchbox. And then, and for this reason, we really decided, okay, now we have to finalize, we have to consolidate this tool and make it available for malaria programs wherever they are and if they are interested. So it's not something that is exclusive to the Global Fund. It can be used by any malaria program can say, okay, I'm going to do an assessment in my country. I would like to use this approach in my country. So it's really to be used as a reference assessment. Who are the responsible? So we've been doing the pilots, as I said. We did in Niger, we did in Guinea-Bissau, and we are doing now in Nigeria. It's very important to have multiple stakeholders engagement. It's very important to have the Malaria National Program really leading this process, because once you do the assessment, you will have the findings that will lead to an action plan. So we really need national commitment to make sure that there will be responses to those findings or those issues that were identified by the malaria matchbox. So the idea of the malaria matchbox is not only like to be an assessment that will bring you findings, but really to help malaria stakeholders to have to think on an action plan to respond to those gaps. So very important, just finalizing this answer, very important is to have the malaria programs really leading this process. Is very important, but it's really important also to have the commitment, the engagement of civil society and communities both working, but also those affected by most affected by malaria. So, for instance, if you have refugees or IDP associations, if you have organizations of women associations, so it is really important to involve them in this process, and also technical partners. So we really are trying to do this a very multi-stakeholder commitment. So can civil society do that? I think it really depends. As I say, that this is a resource that you can use it. You can use it as a national assessment, but you can also use it for, let's say, advocacy purposes. You can also, as I say, is really a resource too that can be used for information, that can be used to raise the awareness of people about human rights and gender issues. So we really hope that the audience will really access this resource and use it as the way that it really fits for them.
Okay, thank you very much, Uli. So I have another question for Alexandrina. So the question is, which category or group of people we refer to as key population? So I think, Alexandra, you probably clarify which group of category of people we refer to as key population. So I think there is an issue around language between malaria and HIV, but Alexandrina, you can help us to clarify. And then the second question, Alex, is so it's like a comment into a question from Mokulu that says a major problem, country face major problem in funding allocation. For the proposal to be sound, they have mosquito net, RDTs and ACTs take up to 70% of the spending of their grants. So even when vulnerable populations are identified, countries are left with little resources which are allocated to service delivery, so which are also included in the PAR. So Alexandrina, the question for you is, can catalytic fund be a special component for funding requests, and I think probably for the use of the matchbox or for CRD issues. So can catalytic fund be a special component of funding requests? And the last question, Alexandrina, is the matchbox best used at the start of the program, or can the results be applied during the program? So when is the best time to use the matchbox in a malaria program? So Alexandrina, if you can hear us, please go ahead. Thank you.
Thank you, Olivia, and thanks to everyone for the great and very insightful questions. On the reference to key populations, in the Global Fund understanding across the 3 diseases, the key populations are those population groups that have a key role to play in upholding their own health. So they are key because they are key partners in the response. For malaria, we speak more about the people at high risk that are underserved, but face barriers in accessing services, very much in line with what the Matchbox tool uses as a language and very much in line with what my colleague Uli was presenting. So we're not referring to key populations in the HIV sense of the term. The key populations will be different for each disease. We speak about those population groups that are at risk and that need to be involved and participate meaningfully in order for the response to be specifically tailored to their needs. On the second question, on the challenge, right? The challenge of fitting it all into an allocation and into a funding request. We need to understand that, yes, it is super important for us to assess and address the social determinants of health. It is super important for us to understand what are the socioeconomical and cultural and political and geographic barriers to services. However, it is not the role of the malaria elimination program alone to handle this specific piece of work. And all the efforts around assessing and addressing barriers should not come from one specific allocation. It can come from a portion of the efforts aimed at resilient and sustainable services for health. So it is important that we understand better across the diseases how we can assess inequities and how we can address inequities, and how do we best coordinate the efforts of various partners. So to respond to your specific question on the malaria-specific interventions taking up most of the share of the allocation, it is important to look holistically at all that the country is eligible for in terms of what is outlined in the allocation letter that the country has received. And it is important to decide what is the best avenue to include such efforts in the funding request. It can be part of the RSSH efforts. It can be part of efforts integrated across the 3 diseases. It can be part of a malaria funding request. Very much it's going to depend on how the country dialogue is going to go, on how the meaningful engagement and involvement of all the relevant partners is going to lead to the prioritization and decisions in that regard. Just to say that the malaria program has an important voice and has an important leverage of raising all these issues with the ministries of health, with other relevant partners and stakeholders. It is also really important that that voice of a malaria program is supported by the civil society. It complements the voice of a malaria program, and they work together. And on a question that appeared in the Q&A about the involvement of the civil society groups, it is one of the eligibility requirements of a CCM. A country is only eligible to apply if it ensures a meaningful engagement process, if it ensures a transparent process for the funding request development. And by doing so, it's not about involving only usual suspects at national level. It's about having truly consultative processes where all voices are heard. And I have a feeling I'm forgetting one question, Olivia. About the best timing of implementation of a malaria matchbox. The answer would be at any time, you need to have a critical look on what are the bottlenecks, what are the reasons why the program is not reaching its targets and its goals. Anytime you need to understand how to better tailor your interventions, the malaria matchbox can provide the answers that you need. So it is useful at the startup of a program. It is useful during the implementation of a program as a wake-up call, helping us complement the quantitative data that we have in terms of are we reaching the right people with the right set of interventions in order for the response to be effective. It is useful basically at any point because it provides information that helps you tailor the response. And I'll stop here. Maybe just say it's also super useful during the malaria program reviews. And thank you so much to my colleagues who are helping me respond to all these wonderful and very insightful questions.
Okay, great. Thank you very much, Alexandrina. Thank you very much. So the last question for Jessica. So Jessica, we are receiving questions on the Facebook Live. So you presented all of the lesson learned and the GRP reports from the last cycle, 2017, 2019. And then we also saw a lot of recommendations from the GRP for window 1 for this year. So how can you, or how can anyone explain that there's still a lot of recommendations from the GRP this year, even after all the recommendations that they made during the last cycle? So does this mean that countries still don't understand clearly how to apply human rights, gender, and social issues or community issues in malaria grants? And what do you think needs to be done about it to improve so that window 2 and window 3 we probably see less comments from the GRP?
Well, thank you very much for that question. That's a really, really complicated question. I think part of it has to do with the funding allocation, which was discussed before. But as I mentioned in my presentation, malaria programs have historically been top-down, meaning that the community level engagement has not always been there. So I think that there at the country level needs to be much more done to have community level actors work with the NMCPs to make sure that those populations are covered. The other thing that, as I mentioned in my presentation, that I think is going to be really important, just like Burundi did and just like Madagascar did, but Madagascar was sent back for iteration, which is always a challenge, is that you need to understand who it is they are, who are those populations? Where are they? What is the number? And then also specifically, what interventions can you provide to them to reduce their disease burden? So I'll stop there if I haven't answered that, but I also can say that we are doing a lot of work with countries. There was a question about Nigeria. We're working with countries to review their funding requests, and it's an ongoing process. Thank you.
Okay, thank you very much. Thank you, Jessica, for your answer. We do have a lot of comments in the chat. It's mainly lot of great comments from participants, very good presentations. Thank you to the panelists from Rwanda, from Zambia, Carol from Zambia, Corinne Karema from Rwanda. And so many people are saying to all of you, thank you for your presentation. It was very clear and it was very, very useful, especially at this time. And so we are very thankful to have the opportunity to have you all with us. So this is the end of our webinar introducing the malaria matchbox. So we thank you very much. So panelists, if you can turn on your video, we will take our family picture. But yes, we wanted to thank you all and thank you to all the participants who stay with us until the end. So right after, we will share the PowerPoint presentation with you, and we'll share all the documents around about the webinar by email, including the tool, and also any other documents that we will receive from the panelists. We will share that with you at the end. So you have a lot of thanks from all the participants, and we just want to quickly tell you that next week, same time, we'll have the same webinar but in French. So for all the Francophone countries, we'll introduce the malaria matchbox with the Global Fund and with also other partners, and we'll have the NMCP, the National Malaria Control Program from Niger, joining us. And on July 23rd, we're going to have a webinar training on long-lasting nets, and we will talk about community engagement and civil society engagement, and the training will be done in collaboration with the private sector. So please save those dates for the next webinar. And thank you all the panelists, Alexandrina, Jessica. Thank you very much. Thank you for your time. And we look forward to have you for many other webinars and training on malaria. Thank you very much.